Good morning, and welcome to another reading of another one of Dr. Ray Peat's articles. This one's called Heart and Hormones, and you can find this on his website, raypeat.com, in the article section. This is how it goes. The heart's unique behavior has given cardiologists a particularly mechanical perspective on biology. If a cardiologist and an oncologist have anything to talk about, it's likely to be about why cancer treatments cause heart failure. A cardiologist and an endocrinologist might share an interest in quote-unquote cardioprotective estrogen and quote-unquote cardiotoxic obesity. Cell physiology and bioenergetics aren't likely to be their common interest. Each specialty has its close involvement with the pharmaceutical industry shaping its thinking. The drug industry has been lowering the numbers for cholesterol, blood pressure, and blood glucose that are considered to be the upper limit of normal, increasing the number of customers for their prescription drugs. Recently, publications have been claiming that the upper limit of the normal range of heart rate should be lower than 100 beats per minute. This would encourage doctors to prescribe more drugs to slow hearts. But the way the evidence is being presented, invoking the discredited quote-unquote wear and tear theory of aging, could have many unexpected harmful consequences. It would reinforce existing misconceptions about heart functions. A few decades ago, diuretics to lower blood pressure and digitalis/digoxin to increase the heart strength of contraction were the main treatments for heart disease. In 1968, the annual number of deaths in the U.S. from congestive heart failure, in which the heart beats more weakly, pumping less blood, was 10,000. By 1993, the number had increased to 42,000 per year. More recently, the annual number of deaths in which heart failure is the primary cause was more than 55,000. During these decades, many new drugs for treating heart disease were introduced, and the use of digoxin has decreased slightly. People with heart failure usually live with the condition for several years. At present, about 5.7 million people in the U.S. live with heart failure. The prevalence of and mortality from other cardiovascular diseases, such as hypertension and abnormalities of the coronary arteries, are higher, but congestive heart failure is especially important to understand because it involves defective function of the heart muscle itself. Although Albert St. George is known mostly for his discovery of vitamin C and his contribution to understanding the tricarboxylic acid or Krebs cycle, his main interest was in understanding the nature of life itself, and he focused mainly on muscle contraction and cancer growth regulation. In one of his experiments, he compared the effects of estrogen and progesterone on rabbit hearts. The basic property of the heart muscle is that when it beats more frequently, it beats more strongly. This is called the staircase effect, from the way a tracing of its motion rises, beat by beat, as the rate of stimulation is increased. This is a logical way to behave, but sometimes it fails to occur. In shock and in heart failure, the pulse rate increases without increasing the volume of blood pumped in each contraction. St. George found that estrogen treatment decreased the staircase effect, while progesterone treatment increased the staircase. He described the staircase as a situation in which function, the rate of contraction, builds structure, the size of the contraction. Progesterone allowed quote-unquote structure to be built by the contraction, and estrogen prevented that. It's interesting to compare these effects of the hormones to the more general idea of anabolic and catabolic hormones, in which more permanent structures and cells are affected. The rapid and extensive alteration of contraction and relaxation made possible by progesterone is also produced by testosterone, and that's from Sang et al. 2009. Things that increase the force of contraction are called inotropic, and the things that promote relaxation are called lusitropic. Progesterone and testosterone are both positively inotropic and lusitropic, improving contraction and relaxation. Estrogen is a negative lusitropic hormone, and that's from Felice et al. 2011, and also a negative inotropic hormone, and that's from Sitzler et al. 1996. That is, it impairs both relaxation and contraction. Another standard term describing heart function is chronotropy, referring to the frequency of contraction. Because of the staircase interaction of frequency and force, there has been some confusion in classifying drugs according to chronotropism. In a state of shock or estrogen dominance, an inotropic drug will slow the heart rate by increasing the amount of blood pumped. This relationship caused digitalis' effect to be thought of as primarily slowing the rate of contraction. That's from Willens and Keyes, 1941. Though its main effect is positively inotropic, it was traditionally used to treat edema by stimulating diuresis, which is largely the result of its inotropic action. Progesterone and testosterone's inotropic action can also slow the heartbeat by strengthening it. I think it was a little before St. George's heart experiment that Hans Selye had discovered that a large dose of estrogen created a shock-like state. Shock and stress cause estrogen to increase and decrease progesterone and testosterone. About 30 years after St. George's work, people began to realize that digoxin and other heart-stimulating molecules can be found in animals and humans as metabolites of progesterone and possibly DHEA. That's from Samogi et al. 2004. The regulatory proteins that are involved in estrogen's negative lucy and inotropic actions, decreasing pumping action, have been known for over 20 years to be regulated by the thyroid hormone to produce positive lucy and inotropic actions on the heart, increasing its pumping action. And thyroid's beneficial effects on heart and skeletal muscle have been known empirically for 100 years. However, drug-centered cardiologists reviewing the currently available drugs approved by the FDA have typically concluded that, quote, drugs targeted to achieve these objectives are not available, unquote. And that's from Chatterjee 2002. I guess I should say close quote. Okay, moving on. When a muscle or nerve is fatigued, it swells, retaining water. When the swelling is extreme, its ability to contract is limited. Excess water content resembles a partly excited state, in which increased amounts of sodium and calcium are free in the cytoplasm. Energy is needed to eliminate the sodium and calcium, or to bind calcium, allowing the cell to extrude excess water and return to the resting state. Thyroid hormone allows cells' mitochondria to efficiently produce energy, and it also regulates the synthesis of the proteins phospholambin and calciesquistrin. Probably pronounced that incorrectly, so sorry. That control the binding of calcium. When the cell is energized by the mitochondria working with thyroid, oxygen, and sugar, these proteins rapidly change their form, binding calcium and removing it from the contractile system, allowing the cell to relax, to be fully prepared for the next contraction. If the calcium isn't fully and quickly bound, the cell retains extra water and sodium and isn't able to fully relax. Heart failure is described as diastolic failure, when the muscle isn't able to fully relax. In an early stage, this is just a waterlogged, that's from Iseri et al. 1952, fatigued condition. But when continued, the metabolic changes lead to fibrosis and even a calcification of the heart muscle. Many children approaching puberty, as estrogen is increasing and interfering with thyroid function, have quote-unquote growing pains, in which muscles become tense and sore after prolonged activity. When hypothyroidism is severe, it can cause myopathy, in which the painful swollen condition involves the leakage of muscle proteins, especially myoglobin, into the bloodstream, allowing it to be diagnosed by a blood test. The combination of hypothyroidism with fatigue and stress can lead to the breakdown of death of muscle cells, or rhabdomyolysis, or myolysis, I should say. The blood lipid lowering drugs, statins, and fibrates impair mitochondrial respiration. That's from Seto et al. 1995, 1994, and Brunmeier et al. 2004. And increase the incidence of rhabdomyolysis from Barker et al. 2003 and Wu et al. 2009 and Fala et al. 2013. Interference with coenzyme Q10 is not the only mechanism by which they can cause myopathy. That's from Nakara et al. 1998. The harmful effect of lowering cholesterol seems to be relevant to heart failure. And here's a quote. In light of the association between high cholesterol levels and improved survival in HF, statin or other lipid-lowering therapy in HF remains controversial. That's from Horwich, 2009. And HF meaning heart failure. Moving on. Heart muscle and skeletal muscle are similar in their structural responses to interference with mitochondrial functions, namely swelling, reduced contractile ability, and dissolution. When myoglobin has been found in the blood and urine, it has been assumed to come from skeletal muscles, but the heart's myoglobin has been found to be depleted in a patient with myoglobinuria, and that's from Lewin and Mascarello, 1966. When heart failure is known to exist, similar changes can be found in the skeletal muscles, and that's from Van der Ent et al. 1998. Stress in the form of pressure overload or overactivity of the renin-angiotensin system and sympathetic nervous system or adrenergic chemicals, or a failure of energy caused by diabetes, insulin deficiency, or hypothyroidism causes a shift of energy production from the oxidation of glucose to the oxidation of fatty acids, with the release rather than oxidation of the lactic acid produced from glucose. This sequence from reduced efficiency to energy production to heart failure can be opposed by agents that reduce the availability of fatty acids and promote the oxidation of glucose. Niacinamide inhibits the release of free fatty acids from the tissues, and thyroid sustains the oxidation of glucose. This principle is now widely recognized, and the FDA has approved a drug that inhibits the oxidation of fatty acids, and that's raloxifene, but which has serious side effects. Glucose oxidation apparently is necessary for preventing the intracellular accumulation of free calcium and fatty acids. The calcium-binding protein, which is activated by thyroid and inhibited by estrogen, seems to be activated by glucose and inhibited by fatty acids. There's several studies referenced throughout that paragraph. Diabetes or fasting increases free fatty acids and forces cells to shift from oxidation of glucose to oxidation of fatty acids, inhibiting the binding of calcium. That's from McKnight et al. 1999. Providing a small amount of sugar, 0.8% sucrose, in their drinking water restored the calcium binding and heart function without increasing either thyroid hormone or insulin. Serum glucose was lowered as the ability to oxidize sugar was restored by lowering free fatty acids. Activity of the sympathetic nervous system is lowered as efficiency is increased. Digoxin stimulates mitochondrial energy production in skeletal and heart muscle. That's from Sigonil et al. 1982. Increasing the oxidation of glucose rather than fatty acids, supporting the effect of thyroid hormone. The statins have the opposite effect, decreasing the oxidation of glucose. One of estrogen's effects is to chronically increase the circulation of free fatty acids and to favor the long-chain polyunsaturated fatty acids such as EPA and DHA. These fatty acids, which slow the heart rate, that's from Kong and Leaf, 1994, extend the excited state and are negatively inotropic. There's several studies referenced there, are being proposed as heart protective drugs. EPA and alpha-linoleic acid also prolong the QT interval. There's another study there. Many publications still promote estrogen as a cardioprotective drug, but there is now increased recognition of its role in heart failure and sudden cardiac death. A prolonged excited state, action potential, and delayed relaxation, QT interval, are known to increase the risk of arrhythmia and sudden death. And estrogen, which causes those changes in humans, causes sudden cardiac death in susceptible rabbits, with an adrenergic stimulant increasing the arrhythmias, and progesterone and androgen preventing them. Progesterone's protective effect seemed to be the result of accelerating recovery of the resting state. That's from Chang et al. 2012. Estrogen's interactions with adrenaline in promoting blood vessel constriction has been known for many years. Progesterone blocks that effect of estrogen. Environmental estrogens such as BPA can exacerbate ventricular arrhythmia caused by estrogen. That's from Yan et al. 2013. The hearts of mice genetically engineered to lack aromatase, the enzyme that synthesizes estrogen, were more resistant to damage by being deprived of blood for 25 minutes. That's from Bell et al. 2011, leading the authors to suggest that aromatase inhibition might be helpful for heart disease. In the stressed, energy-depleted failing heart, muscle cells die and are replaced by connective tissue cells. The growth produced by overexposure to adrenergic stimulation leads to stiffening and reduced functioning. However, under the influence of thyroid hormone, a high workload leads to functional enlargement, which simply increases the pumping ability. Because of the traditional belief that heart cells can't replicate, the functional growth was believed to be produced purely by the enlargement of cells, and in recent years the existence of stem cells able to create new heart muscle has been recognized. Thyroid is likely to be one of the hormones responsible for allowing stem cells to differentiate into cardiomyocytes. There we go. In this context of cellular differentiation as a lifelong process, we can see the changes of a failing heart as a differentiation which is forced to take an inappropriate course. The calcification of blood vessels caused by phosphate excess and vitamin K deficiency involves the expression of a protein which has its proper place in the skeleton. The replacement of heart muscle by fibrous connective tissue and even bone is a basic biological problem of differentiation, and the responsible factors, stress, increased estrogen, deficient thyroid hormone, suppression of glucose oxidation by fatty acids, etc., are involved in the problems of differentiation that occur in other degenerative processes, such as sarcopenia, dementia, and cancer. There have been arguments about the nature of wound healing and regeneration regarding the origin of the new cells, whether they are from the de-differentiation of local cells or the migration of stem cells. The evidence is that both can occur, depending on the tissue and the situation. The deterioration of an organ is probably not a question of a lack of stem cells, but of changed conditions causing them to differentiate into something inappropriate for the full functioning of that organ. Various stresses can cause cells to de-differentiate, but hypoxia is probably a common denominator. In the absence of estrogen, hypoxia can activate the quote-unquote estrogen receptor. Estrogen is in some situations a hormone of de-differentiation, facilitating the formation of new cells in stressed tissues, as aromatase is induced. However, the presence of polyunsaturated fats, tending to increase in concentration with age, causes the processes of renewal to produce exaggerated inflammation, with prostaglandins participating in the processes of development and differentiation. Estrogen, by increasing the concentration of free fatty acids, especially polyunsaturated fatty acids, contributes to the metabolic shift away from glucose oxidation towards the formation of lactic acid and away from full organ-specific differentiation. This perspective puts heart failure, cancer, and the other degenerative diseases into the same biological basis and shows why certain conditions and therapies can be appropriate for all of them. Problems that seem relatively trivial become more meaningful when they are seen in terms of these mechanisms. Some problems that become very common by middle age are quote-unquote palpitations, orthostatic hypotension, orthostatic tachycardia, and varicose veins. The negative inotropic effect of estrogen in the heart has a parallel in the smooth muscle of veins, in which the muscles are weakened and their distensibility increased when estrogen isn't sufficiently opposed by progesterone. This allows the veins in the lower part of the body to be distended abnormally when standing, reducing the amount of blood returning to the heart so that the volume pumped with each stroke is small, requiring faster beating. The reduced blood volume reaching the brain can cause fainting. When it becomes chronic, it can lead to progressive distortion of the veins. An excess of estrogen is associated with varicose veins in men as well as women. There are many studies cited right there. The simplicity of things such as supplementing thyroid, progesterone, and sugar, avoiding an excess of phosphate in relation to calcium, and avoiding polyunsaturated fats makes it possible for people to take action themselves without having to depend on the medical system. Most physicians still warn their patients of the dangers of thyroid supplements, especially the active T3 hormone for their heart, but in at least one specialty, its value is recognized. Heart transplant surgeons have discovered that administering T3 to the brain-dead heart donor before removing the heart prevents its viability and function in the recipient. And that's from Novitsky, 1996. Around this time, the manufacturers of Cytomel conceived the idea of marketing it as a quote-unquote heart drug, which would make it much more profitable. A little bit too far. There we go. Another technique that is easy to use to lower blood pressure and improve heart rhythm is to breathe into a paper bag for a minute or two at a time to increase the carbon dioxide content of the blood. This has a vasodilating effect, reducing the force required to circulate the blood, and reduces anxiety. Rhubarb and emodin, a chemical found in rhubarb and cascara, have been found to have heart protective actions. A considerable amount of research showed that vitamin K is effective for treating hypertension. But again, most doctors warn against its use because of its reputation as a clot-forming vitamin. Recently, the value of the quote-unquote blood thinner warfarin, a vitamin K antagonist, has been questioned for people with heart failure. And that's from couple of studies there. There have been several recent warnings about the production of arrhythmia by drugs that increase serotonin's effects. That's from Stillman et al. 2013. Measuring the speed of relaxation of the Achilles tendon reflex twitch is a traditional method for judging thyroid function, because in hypothyroidism, the relaxation is visibly delayed. The same retardation can be seen in the electrocardiogram as a prolonged QT interval, which is associated with arrhythmia and sudden death. Insomnia, mania, and asthma are other conditions in which defective relaxation is seen, under the influence of low thyroid function and an insufficiently opposed influence of estrogen. As usual, we have quite a few references down here at the bottom of his article. And I hope that you all enjoyed this reading and that you learned something. And don't forget to subscribe and set the notification bell so that when I publish another one of these, you'll be notified of that. Again, this is for educational purposes only, and I hope that it is helpful in your education, and I will see you next time.